This is a 40 years old lady who presented with a solid mass of 4.5 to 4.8 centimeter in the left adrenal region, and she was investigated for cortisol secreting tumors, for pheochromocytoma, for aldosteronoma, and on investigations it turned out to be a non-functioning solid adrenal mass. So we decided to perform a laparoscopic left adrenalectomy in her. Let's discuss the procedure now. The port placement for nephrectomy, whether that is a simple nephrectomy or radical nephrectomy or a pyeloplasty or a pyelolithotomy or a ureterolithotomy for a stone in the proximal ureter remains the same. And I use the triangular method for my procedures on the kidney, as I already discussed in the previous video of a lady with a BMI of more than 40. The steps of again the pyeloplasty, the pyelolithotomy, ureterolithotomy, simple nephrectomy, radical nephrectomy, nephrouretrectomy, as well as adrenalectomy are the same. So there is a mobilization of the colon, and on the left side we mobilize the colon up to the pelvic brim. Some may ask that if you are performing an adrenalectomy, a procedure which is performed on the adrenal gland, which is above the superior pole of the kidney, why are we going to mobilize the colon up till the pelvic brim? Well, the situation may vary accordingly, but usually we mobilize the colon up till the pelvic brim lower down, and we also mobilize the spleen up till the crurum of the left diaphragm. I would answer this question with the comment that I usually call this step as the homework. And if you do the homework by making the field as much clear to yourself, the final steps of the procedure will be extremely easy. So a little bit of hard work here can save you a lot of time at the end of the procedure, and also it can make the procedure extremely easy. So once again I would emphasize that by mobilizing the spleen up till the left crurum of the diaphragm will just drag the colon due to its weight, the weight of the spleen. It will drag the colon towards the midline or medially, and thus the area where you are working, that is the adrenal, will be very easy to dissect. So we are doing our homework here. We are preparing our battlefield. You can see here the adrenal is in vision now, and we can also see the tail of the pancreas. The arrow is pointing towards the tail of the pancreas. So we come a little more downstairs. It will depend upon the habitus of the patient, whether it is fatty or it is thin lean. All these amount of dissection or the extent of dissection would depend upon that. So after mobilization of the colon, we identify the gonadal vein, and after identifying the gonadal vein, we just follow it, and this leads us towards our first landmark, that is the renal vein. Of course, we are discussing the left-sided procedure here. This is the renal vein here. The arrow is pointing towards it. So we dissect this and expose this renal vein. As we all know that the main vein of the adrenal gland is draining into the renal vein. So identifying the renal vein will make it easy to identify that adrenal. So this is gonadal vein. So this is you will now see the arrow will be pointing towards it. Now this is the adrenal vein. So in case of pheochromocytoma, clipping of this vein before manipulating the adrenal gland is of utmost importance. As we all know, on the right side, this adrenal vein is draining into the IVC directly in 99.9% of the cases. However, there are some variations where even the right adrenal vein may drain into the renal vein. So we dissect this adrenal vein carefully with the small 5 millimeter right angle. And then we clip this vein. After clipping this vein, we will be able to cut it, and thus the adrenal will be detached from the main vessel. This will give us confidence, as well as there are less chances of complication. Here you can see that we are going behind the adrenal now, and the psoas muscle can be seen. So the next step is to separate the adrenal gland from the upper pole of the kidney. This step is extremely important. We are doing a horizontal dissection, and we are not going deep into this tissue, because going deep, there are two chances. One, we can injure the small vessels which are exchanging between the gerota, the upper pole, with the adrenal gland. Or a more important thing, which we'll discuss in this video, is that we must take care of renal arteries, because if we are going so close to the parenchyma of the upper pole, there are chances that there may be a small branch of the renal artery, and that may be compromised. It's a small artery, will not be very lethal. However, if we injure that, then the clipping may compromise the upper pole. That's why here we are dissecting very carefully, looking for pulsations. You can see the pulsation at the tip of our ligature. So that is this. Yes, this is the branch of the renal artery to the upper pole. So we are going slowly and gradually. Small bits are taken, and we do not take anything unless and until we are 100% sure that there is no small artery in it. We still can see the pulsations here. So we are going away from the renal parenchyma here and dissecting towards the adrenal gland. And this tissue most probably is containing one of the adrenal arteries, which may be a branch from the upper polar artery. So we just clip it and then cut in between, and also taking care not to injure the branch to the upper pole. This will also give us a little more confidence, so the adrenal gland will be more mobilized. Now we are sure that there are no vessels anymore that exchange between the kidney and the adrenal gland. So our dissection is more bold, and we can see very clearly that the kidney is, or the adrenal gland is, completely separated from the kidney. Laterally, there is nothing much in the dissection. is only fibrofatty tissue, but small vessels may also be there in that tissue. So care must be taken. However, the posterior dissection and the lateral dissection is almost complete. Now we come to the medial dissection. Here we can see the normal adrenal gland along with the big adenoma. On this side, care must be taken medially because splenic vessels may be encountered during this dissection. So now you can see that the homework that we did has paid off here. The main procedure has been so quick and clean. These are small vessels, and we can also see that there is a small vessel coming to the adrenal gland, most probably the inferior phrenic artery. Branches from the inferior phrenic artery to the adrenal gland. Here. We further thin out this tissue, and finally there will be just one stalk, and we just clip it and then divide it with scissor or with ligation, and so the adrenal gland will be completely free. Small peritoneal adhesions. So the homework has paid off. Good mobilization of spleen, good mobilization of the colon, and then finding the renal vein, and then clipping the adrenal vein. The rest of the job becomes extremely easy, and we place this specimen into a glove bag, and then we remove it through the portal visual port side. Thank you very much for watching the procedure.